We're delighted to have you here to talk about type 1 diabetes and your CPMC results. First, we're going to have Dr. Haddad speak, and she is the head of endocrinology at our neighbor, Cooper University Hospital. She did her medical degree at St. Joseph University in Lebanon, her residency at Cooper, and then her fellowship at the University of Pennsylvania before returning back to Cooper to work in endocrinology. So we're delighted that she's here and excited to hear what she has to share with us.
Thank
Welcome.
you. Please stop me any minute if you have any question. I'm going to try to make it as easy and accessible as possible. If you have any question along the line, let me know. I just wanted to give you an idea first about diabetes in general in the United States. This is all type of diabetes, particularly the most common type, type 2 diabetes. Are you familiar with the difference between type 1 and type 2? No. Type 2 diabetes is the most common diabetes we see in the United States. This is usually happen in patients who are overweight, and as they get older, the incidence of diabetes gets higher, usually around 40, 45. But as I'll show you, the incidence of type 2 diabetes is starting to get much higher even in childhood. So this graph here shows you the incidence. The darker the color, the higher the incidence of progression to diabetes in several states. So from 1990 to 2001, you'll see that there is a higher percentage of patients with diabetes in the United States. And most of it is related to this: increase the girth of our nation. Unfortunately, with the type of food that we're eating and the lack of activity, with the technology evolving, we're more sedentary. So all this predisposed to obesity, which in turn predisposed to the most common cause of diabetes, which is obesity-related type 2 diabetes. And what you see in the picture, as I mentioned earlier, is the kids are also obese. And what is that doing to them? It's increasing the risk of diabetes at a much earlier age. In the past, type 2 diabetes was unheard of in kids. Any kid with diabetes was type 1. But because of the rate of obesity, we're seeing a lot more type 2 diabetes in this generation. And as you could imagine, just eating a Wendy hamburger here is 1,420 calories, 1,400 calories in one hamburger, not to mention the fries nor the Coke. So in general, most people without significant activity need about 1,800 calories a day. So that's your full, one hamburger is your full caloric intake. But more than 16 million Americans have diabetes, very, very high incidence. And 95% of them are type 2 diabetes, which is related to obesity. But only 5 to 10% have type 1 diabetes, which we'll be talking about today.
Is the condition the same, however, whether you have type 1 or type 2,
the implication and the complication?
Are the
yes.
same? Okay.
Yes. So type 1 diabetes happen mostly, there's two peaks of age, age 4 to 6 and 10 to 14. It happened at any age, but particularly the higher incidence is very early on, and then in the pubertal age between 10 to 14, but also in adult, as I will talk to you about. The prevalence in the US is about 2 per 1,000, and new cases are expected to double between 2005 and 2020 in some part of the country and some part of the world as well. And we're not really sure why are we predicting or the increased incidence of type 1 diabetes. Type 2 diabetes we understand because it's related to obesity and the increasing rate of that. Just to tell you when we talk about diabetes, what causes diabetes. This is the anatomy of the organ responsible for the physiology of the blood sugar in the body. What you see here, this is the pancreas, which is the organ that secretes insulin. That's the most important hormone to regulate your glucose. Glucose means blood sugar. So it's behind your stomach here, and that's the shape of it. It contains cells called beta cells that secrete insulin. So you hear a lot of people talking about beta cell dysfunction or malfunction for one reason or another, and that's what's causing diabetes. In type 2 diabetes, the insulin is present, but it doesn't work very well because of the fat cell. In type 1 diabetes, insulin isn't present at all. There's a deficiency of insulin secretion by the pancreas. And that's a big difference between both disease and a big difference in the way we treat it. Because without insulin, you cannot live. So if you're totally insulin deficient, like in type 1 diabetes, not getting insulin, you cannot survive. So this is just to explain to you what happened in particular in type 1 diabetes. I mentioned that the defect is the absence of insulin. And what happens when you don't have insulin? You're going to have an increase, hyperglycemia, means increase in the blood sugar, in the bloodstream. Why is that? Because insulin is very important to tell the liver not to produce blood sugar. The liver, even when you're not eating in the morning, some people wake up who have diabetes with high blood sugar, even though they're not eating at night. And they say, well, how come my blood sugar is high and I haven't eaten much at bedtime? Because the liver normally produces glucose. And the function of the insulin is to suppress that liver production of glucose. So without insulin, the liver is going to pour glucose into the bloodstream. It also going to prevent the muscle and fat from using glucose. So the insulin helps push the glucose into the fat and the muscle cell to produce energy and use the glucose for energy. So with the absence of insulin, you cannot dispose of glucose and you cannot suppress glucose production by the liver. This will result in high glucose level in the blood, which in turn will cause increased glucose level in the urine. And one of the symptoms of uncontrolled diabetes is urinating a lot, because when the body has too much glucose, it's trying to get rid of it through the urine by excreting it and excreting water with it. That's why the symptoms of urination occur. What this shows is a natural history of pre-diabetes. What happened? When do you get diabetes? This is the beta cell that I mentioned. So in a normal person, you have 100% mass of beta cell. Normal pancreas has normal amount of beta cells. When you have a genetic predisposition for that kind of type 1 diabetes, not everybody would develop diabetes. You need a genetic predisposition and you need something else that happened along the line. And we don't really know what that's something else. We call that a putative trigger. It could be a viral infection. It could be immunization. It could be exposure to certain type of food early on, like cow's milk. There's a lot of speculation about what's triggering this destruction of the pancreas in people who are genetically predisposed to diabetes. But when that happens, you have what we call insulitis, which is an inflammation or destruction of the pancreas that will destroy the beta cell function, causing first a pre-diabetes stage and then frank diabetes. This process from here to here could take few weeks in some individual. In others, it could take few years. And in patients with type 1 diabetes in adult, it often you have that process that takes few years. It's a late onset. The destruction is more slow, progressive. This is why you don't have the acute early onset of type 1 diabetes. And when you get the symptoms of diabetes, which I will mention to you later, it usually means that you have only 10% of your beta cell remaining. So it needs a complete destruction to have symptoms. So late onset type 1 diabetes, about half of patients with type 1 diabetes are diagnosed after the age of 18. So it's not unheard of. Autoimmune process may differ and is slower, like I mentioned. Autoimmune meaning when you self-destruct your organ and no longer produce insulin. This onset of type 1 diabetes in adult is often mistaken for type 2 diabetes. And a lot of physicians think that type 1 diabetes is just defined by age. So if you're young, it's type 1. If you're old, it's type 2. It's not really correct. It depends on the clinical presentation, not just the age of the patient. As I just mentioned, now we're seeing a lot more type 2 diabetes in children. So if you have a kid who's obese and has diabetes, most likely it's type 2. And there are ways to distinguish between them by doing certain blood tests, such as the insulin antibody and glutamic acid decarboxylase antibody. They're just fancy word to detect those antibodies are attacking the pancreas and causing the destruction. So if you have those antibodies, you more likely have type 1 diabetes. And it's important to distinguish type 1 diabetes in adults because oral agent, which mean oral medication, don't work. And most people always get started on oral medication. But when you present with severe symptoms and very high blood sugar, the only treatment that is necessary is insulin. And that's the fastest and most effective treatment. But still some patients or physicians start with oral agent and they found that after a few months, a year, it's ineffective and they switch to insulin. They just didn't recognize that it was a type 1 diabetes in slow evolution. Any question? So what is the risk of type 1 diabetes if one of your family members have type 1 diabetes? Now, you could get it even if nobody has diabetes in your family, and the risk is about 0.4%. Now, if you are a mother with diabetes, type 1 diabetes, the risk of having a child with type 1 is 2 to 4%. If you're a father, the risk is 5 to 8%. Men always cause more problems. Just kidding. And if both parents have diabetes, the incidence to have a child with diabetes could be as high as 30%. Now, how do we define diabetes? How do we diagnose diabetes? By blood test, by fasting blood test. So that's fasting blood glucose. And the cutoff is 126. It used to be 140 in the past. It dropped to 126. So anybody who had two value of fasting blood sugar over 126, by definition, have diabetes. Now, there are patients who don't have a normal sugar, but yet it's not quite abnormal to determine diabetes. We call that impaired fasting glucose. So it's a pre-diabetes stage. And it's important to recognize those patients because they still have risk of complication of diabetes, particularly the heart disease and the stroke, what we call the macrovascular, the big vessel complication. So we should tell patients if they're obese and they have those range of fasting blood glucose that they need to do something about it. It may not necessarily be medication, but definitely lifestyle changes. On the other hand, you could also diagnose diabetes if you have a 2-hour blood sugar measured after giving glucose that is over 200. We call that glucose tolerance test. We often don't need to do that. The fasting glucose is enough. But if you happen to have like a routine blood test and your sugar is 300, that's diabetes. So what are the symptoms of diabetes? Important to note that some patients are asymptomatic and often detected on routine blood tests. So most people get a routine blood test that include glucose when you go do your physical or blood test twice a year. The glucose there is included. However, when the destruction of the pancreas becomes more rapid, you could present very symptomatically with weight loss, and people like it because they eat and they lose weight and they're happy. But that's not healthy. Excessive thirst because you're getting rid of the glucose and water so that you're drinking to compensate the dehydration. You lose weight, you drink a lot, you urinate a lot, you're tired, you have blurred vision, and you may have sores that are not healing well. That could be a sign of high blood sugar. Or occasionally you can present with an acute complication of diabetes called diabetic ketoacidosis, or commonly named DKA. So it could be the initial presentation, or it could be patients who have type 1 diabetes who are not taking their insulin for some reason or another, and they will come to the hospital, to the emergency room with very, very bad symptoms of all of the above. If it's very severe, they can sometimes be obtunded. They could have severe acidosis. You could die if left untreated. So those are, from one extreme to another, the symptoms of diabetes. Any question? So what does diabetes affect? Whether it's type 1 or type 2, those are the organs that diabetes will affect. One is renal failure. It affects the blood vessel in the kidney and causes dysfunction of the kidney. It doesn't function right. And then at some point, if it progresses, it could end up in dialysis. Patient will have to come to the hospital 3 times, or outpatient dialysis 3 times a week to change their blood so that they could survive. If you have decrease in your blood vessel supply in the feet and nerve damage, it could cause infection and loss of toes, foot. A lot of patients have below knee amputation, above knee amputation, related to both blood vessels and what we call neuropathy, nerve damage. Because when you have nerve damage, you won't have good sensation. So somebody could, I have patients walk with a bottle of insulin in their shoes and not knowing it. So the bottle broke and he injured himself and didn't know till it was too late and he had a big infection. So I always counsel patients never to walk barefoot, to always examine their feet and make sure they're in good shape. Yes?
Does it matter how well controlled suppose you really are,
Yeah.
follow up on it, your diabetes is very well controlled. Do you minimize your risk of
Absolutely, and that's why we do a lot of study to look at that, how well we should control it to prevent those complications. There's a lot of evidence showing that if you control your diabetes, you really slow the progression of the disease, particularly for type 1.
You'll still have the tendency, but not
as bad. You never eliminate it, correct.
Okay, thank you.
Yeah. And surprisingly, I have to say it's genetic. I have patients who had the worst, horrible, uncontrolled diabetes, very few percentage of patients, for years and years and years, and yet not a single complication. They just have good genes. But for the most part, people who are uncontrolled will not do well, and people who are controlled in general will do well. Blindness, because it affects the blood vessel in the eye. That's why it's very important for diabetic to see an eye doctor once a year. You'd be surprised how many patients I see who've had diabetes for years and years and years and never heard that they need to see an eye doctor or never knew the importance of keeping up. Because you could have changes in the back of your eyes that you won't feel that will eventually cause progressive blindness and could be prevented by doing laser surgery. Nerve damage we talked about, and I left the last because that's the most important complication of diabetes, cardiovascular complication. Even if patients are on dialysis, amputation, all the horrible complication of diabetes, what kills patients with diabetes is heart disease, particularly type 2 diabetic. That's the number one cause of death. And we take it very seriously because the first heart attack could be silent. So we control all the other risk factors for heart disease, not just the diabetes. We make sure that cholesterol is very low. We make sure that the blood pressure is on target, that they're exercising to prevent that first heart attack. And people with the first heart attack have a much higher risk of having another heart attack. So we try to prevent it from the first time. It's actually to show you how powerful diabetes is as a risk factor for heart disease. A lot of data have shown that if you have diabetes without known heart disease, your risk of developing a heart attack is more than somebody who already have a heart attack without diabetes. Do you follow what I'm saying? Mm-hmm. So if somebody just have high blood pressure and had a heart attack, typically those patients are at very high risk to have another heart attack. But if you have diabetes without known heart disease, you're at higher risk to have heart disease than that person. So it's important to pay attention to that complication. So this is just a picture of what happened. This is a normal retina. If you look at the back of your eyes, this is normal, healthy blood vessel. This is a person with severe complication of diabetes called proliferative retinopathy. So leakage in the blood vessels and all that you could prevent and treat with laser surgery before it causes significant damage, but even better to prevent this from happening by controlling the blood sugar. This is what happened if you do a microscope picture in the kidney. We call that diabetic glomerulosclerosis, which is sclerosis of the kidney. I don't know how better to explain that, but the kidney doesn't filter what needs to be filtered to get excess of the toxin in the body, and you become eventually uremic, requiring dialysis. This is a foot deformity in somebody with diabetic neuropathy. You could see how this could predispose you to develop foot ulceration because of the way you're putting your foot on the floor. And it's important to have good fitting shoes and prevent complication of neuropathy, which could result in that as well. And not to mention the pain. A lot of patients really cannot sleep at night because of pain and numbness in their feet. So how do we manage diabetes? We look at three things. Have you heard of hemoglobin A1C? This is a blood test that the physician will order every 3 to 4 months, or sometimes 6 months if people are doing very well, but typically quarterly, to tell us how overall the diabetes has been controlled. It's a marker of your blood sugar over 3 months. We ask patients to check their sugar and to adjust their dosage of insulin depending on that, but they can't check it 24 hours a day. And this will give us an idea about what it has been. So it's a function of the pre-meal blood sugar as well as the post-meal blood sugar. So it's important to check the sugar, not just before the meal, because half of the time you're living in a post-meal state, or what we call postprandial. So it's important to also pay attention to what happened to your sugar after you eat. So we tell patients to check their sugar 2 hours after the meal. If it's high, we know that the dose of insulin that they're getting is not enough. Or if it's low, that's too much. So it's important to look at both the pre-meal and the post-meal blood sugar and look at the overall marker over a period of 3 months, which is hemoglobin A1C. So beside diabetes, I had mentioned that it's very important to look at the other target that you need to treat to prevent complication, not just in the heart, but also in the kidney. It's very important to keep the blood pressure normal, because if you have high blood pressure and diabetes, it's a double insult to your kidney. You're having even a much higher risk of progression to dialysis with high blood pressure combination with diabetes. You know, a lot of patients are on dialysis because of high blood pressure alone, not with diabetes, although the most common cause of dialysis patient is diabetes. So the combination isn't good. LDL cholesterol, you know, the different part of cholesterol, the LDL is a bad cholesterol. We aim for a very low level, less than 70 in diabetic patient. Less than 80 might be acceptable. Again, I mean, those criteria are not in stone. We do tailor depending on the patient's age, patient's other morbidity factors or other disease that they have, whether or not they're tolerating the medicine. But in general, as a rule, we try to keep the LDL less than 70, even if they don't have heart disease. And that is the same goal as somebody with heart disease without diabetes. If somebody had a heart attack or have any kind of angina, we lower the LDL less than 70. We do the same for diabetic patient. And in A1C, we try to aim for less than 6.5. Again, for some patient, an A1C of 7% is acceptable. 7.5 maybe in older with multiple medical problem where the risk of low blood sugar is too high. But A1C of 8, 9, 10 is really unacceptable. And it's amazing how many patients have A1C in that range. It is sad to see how much uncontrolled diabetes we still see for various reasons. Because it's very difficult to achieve good control without also going into some complications such as low blood sugar. Because you want to try to normalize it and mimic human nature. It's very hard to do when you're trying to do tight control. And that's one of the downside effects from being able to do a good control is having low blood sugar, which is also not a good thing for you. Yes?
How accurate are those tests in the drugstores for like HDL, triglycerides?
Not as accurate as a blood test. The blood test is much better. This is just before moving on to a very short overview of treatment. I just wanted to tell you that we still have a long way to go to improve treatment of diabetes in here. And what this will show is the mortality, the number of people who die related to different disease. So patients with cardiovascular disease and stroke, we're able to improve their mortality. It's going down. We're doing a better job. Patient with cancer, it's kind of flat. Patients with diabetes are still dying and going up. So the incidence of diabetes is higher and the incidence of death from diabetes is higher. So we need to do a better job in controlling patients with diabetes. What are the options that we have? Imagine in the past we had this option, walking with this big insulin pump. I have an insulin pump later on if you'd like to show you how it functioned. But obviously over the years, the technology had evolved from all this big thing to that very small machine that's the size of a beeper that delivers insulin. It's not the only treatment. That's one of the treatment available, a way, I should say, to deliver insulin that's available beside injecting with needles several times a day. What it does here, it gives you insulin. It tries to mimic the pancreas. Every time you eat, you push the button to deliver insulin, and in between, you always have insulin secretion. Because a normal person still have insulin secretion even when you're sleeping, but it's a much lower rate. So we try to give that basal, what we call basal rate, to mimic this. And in addition, we give a bolus of insulin, which means a rapid injection of insulin to control the meal. So what you'll see here, this is a basal insulin. And then, so we have different kind of insulin, one that will give you a steady insulin level, and then one that we call a short-acting that would be injected right before breakfast to control the sugar, right before lunch, and right before dinner. So this is 4 injection. This would be given at bedtime, and this would be given before each meal. And so the kind of insulin we have, it's like one kind is called glargine, if you've heard of Lantus or Levemir. It's a long-acting, supposed to last 24 hours and stay flat, where those short-acting insulin, Lispro or Aspart, Humalog, Novolog, are very short-acting insulin. They work right away. Those are the fastest insulin available. In the past, it was regular. Now we have a different technology to change the insulin. We change one amino acid in the structure and makes it much faster absorption. And then it also will wear off quickly because you don't want it to be on for too long. You just want it to cover the post-meal period.
And you get this with the pump, the insulin pump? Is that how you're getting
Yes,
this?
you could do that with a different injection of insulin, and I'm going to show you that. And you could also do that with a pump.
Okay.
Those are the website, if you're interested in looking more. Those are very tailored for patients, individual, to have more idea about diabetes. What can we do? Can we prevent type 1 diabetes? Unfortunately, so far, we don't have a lot of good ways to prevent diabetes. There have been some trials about giving insulin, even in non-diabetic, for patients at high risk. Doesn't seem to work. There's a lot of research in that area, but so far it's not very promising. There is promise perhaps in future treatment of type 1 diabetes with islet cell pancreas transplant, but that also has problem because it seems that we need a lot of donor for that islet cell. It's not taken up. We're not getting enough mass of pancreas to introduce. And also, when you do that, you have to take certain drugs called immunosuppressant to prevent the rejection of that foreign body. And that by itself can carry long-term risk, more so than giving insulin. So the point is to try to find a technique that will keep viable transplant with less immunosuppressive therapy, and that might be for the future. And I always like to think that there's a light at the end of the tunnel in the horizon. That's one of my favorite places in the world, is to walk on the beach in the morning and meditate. I won't say for a cure for diabetes. That's not on my mind every day, but that's a wonderful thing to be able to do.